Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and avoid the collapsing U.S. healthcare system. So the topic I want to cover today is maybe somewhat controversial, maybe a little bit different than what you've heard before from your clinic. And that topic is why you don't need to donate blood while you're taking testosterone, specifically for elevated hematocrit levels. Many clinics across the country, including ones in my local area, absolutely insist that their patients undergo phlebotomy when their hematocrit starts to rise, and which is very common, especially on injectable testosterone. It's something like 60% of men who are on the shorter acting esters of testosterone, so including cypionate, enanthate, propionate, are going to have hematocrits that at one time or another go above 50%. And many clinics, like I said, locally here and ones that I've interacted with across the country, that's their threshold for making their men, get phlebotomy. And they scare the shit out of them by telling them, you're going to get a blood clot, you're going to get a pulmonary embolism, you're going to have a stroke, you're going to have a heart attack. And 50% is this magic threshold that below that, you're completely fine. And above that, oh God, we're not going to refill your testosterone. You've got to go immediately to the Red Cross, donate blood, whatever. And I'm going to show you some data here, and I think you'll see logically why that is unnecessary. And I hope that eventually these recommendations that these clinics are giving out to patients, which are not evidence-based at all, completely go away. Right now, the current guidelines out there by the Endocrine Society and the American Urological Association, and I think the European Urological Association also recommends this as well for testosterone patients, is they use a cutoff of 54%. And the Endocrine Society specifically says that's the number where you should maybe discontinue therapy and then maybe consider phlebotomy. So, again, with this theoretical risk that levels above that lead to increased blood viscosity and then theoretically increase the risk of developing a clot. Again, a DVT, a clot in your legs, a pulmonary embolism, which is a clot that typically starts in the legs, although it can start other places and goes to the lungs, can certainly be fatal, stroke, heart attack, etc. Well, the data is pretty clear that hematocrit elevations from testosterone and really from all other secondary causes, which I'm going to get into in a second, they're really not associated with increased clot risk. They're not associated with increased stroke risk. And I'm going to show you some data on that here in just a second. But, the final nail has not been put in the coffin on this. So, there may be, I'm fully willing to concede that maybe some studies will come down the road that say, no, there actually is some kind of a risk. And if that's the case, I'll make a video about it. But the overwhelming amount of data as it stands right now shows that you don't need to do this. So I'm hoping eventually, the Endocrine Society and these other associations, they do value evidence-based medicine. It's just that, just like any big agency or organization, things are often slow to change. So I'm optimistic that eventually, at least when it comes to testosterone, they're going to change those recommendations. So for the time being, I follow their guidelines mainly for medical legal reasons. But am I worried if you're walking around with a hematocrit of 55% and you're otherwise healthy that you're going to get a blood clot, stroke, pulmonary embolism, etc.? No. Now, if you have other risk factors for those conditions, if you're morbidly obese, you have a genetic hypercoagulable state, you have hypertension, hyperlipidemia, and you chain smoke, yeah, I'm worried that you're going to get one of those conditions. But not if you're otherwise healthy and not because of you being on testosterone, okay? So why do providers freak out about this, okay? I think there's a fundamental misunderstanding between, well, first of all, this condition, it gets called one of two things. So we should talk about definitions real quick. You hear polycythemia seems to be the most common one. The other term that's kicked around is erythrocytosis, which I kind of prefer because we're really just talking about the erythroid cells. So, red blood cells, essentially. Red blood cells carry hemoglobin. And so when you get your CBC, you get two values that they look at. One is your hemoglobin and one is your hematocrit. And barring some other, issue, they're going to tend to run together. Hematocrit is more of a blood volume issue and a dilutional issue. So if you're extremely dehydrated, your hematocrit will go up. Just because the red cells are concentrated, it doesn't mean that you have more. It just means that they're more concentrated, okay? So we're just going to use erythrocytosis. I may slip in polycythemia, but when I say polycythemia, just keep in mind I mean the same thing. There's two major broad categories of erythrocytosis. There's primary and there's secondary. Both of them result in elevated hematocrits, okay? But primary erythrocytosis, and I'll give you some examples of that in a second, it is associated in most cases with increased clot risk. So DVT, pulmonary embolism, stroke, etc. So what are some examples of primary erythrocytosis? The one, you know, the main one, and this is where all of this frightening data or where this fear-mongering comes from, is a condition called polycythemia vera. Now, polycythemia vera is something I run into actually every now and then in the emergency room. I just had a guy about a month ago that came in with polycythemia vera, and what that is that's a hematological cancer, okay? It's a malignancy, and it's associated with this JAK2 mutation, which is not important, but it involves a mutation in the myeloid precursor cells and erythroid precursor cells in the bone marrow. So typically, in order to get increased red blood cells, you have to have high levels of erythropoietin, or EPO. Okay, it's the hormone made by your kidneys. It's also the synthetic versions are used by long-distance cyclists and athletes to like bump up their hemoglobin and hematocrit levels for a performance benefit. So you hear about EPO doping. Well, that's what that is. So in a primary erythrocytosis, EPO levels are low because there's something wrong in the bone marrow. There is a genetic mutation that is overriding the body's normal control mechanisms, and the bone marrow is pumping out red blood cells. Now, in polycythemia vera, you don't just pump out red blood cells, and this is really important. You also have an increased level of platelets, okay? And in many cases, you actually have slightly elevated white blood cells as well, although not necessarily. And I'm going to show you in a second here this paper. It is not necessarily the hematocrit issue that in primary erythrocytosis that leads to stroke, okay? It's abnormal platelet function. It's abnormalities in the coagulation cascade, you know, that lead to the formation of a clot, okay? So it is not, it really is, your hematocrit number in conditions like polycythemia vera and some of these other genetic erythrocytosis conditions, the hematocrit is not necessarily the thing that puts you at high risk for stroke. And again, these people are at high risk for stroke, for DVT, for pulmonary embolism, and they do tend to benefit, the ones that have high hematocrit, they benefit from phlebotomy. So they, you know, polycythemia vera patients do typically have to donate blood. But interestingly enough, chemotherapy for them works better to reduce their risk of stroke, heart attack, clot, etc., than blood donation does. So they still donate blood. Most hematologists will have them do that. But just lowering the hematocrit in those people, while it does help, it doesn't improve their, or doesn't lower their clotting risk, I should say, as much as undergoing some sort of a chemotherapy regimen, okay? So that's primary erythrocytosis. You have something genetically wrong, either, you know, fundamentally that you inherited or something that you acquired, like probably in the case of polycythemia vera, where you have low EPO levels. There's dysregulation in the coagulation cascade. These people again do benefit from phlebotomy. So that's primary. Now, secondary erythrocytosis or polycythemia. So it's secondary to another cause. Okay, so mainly it's actually a beneficial adaptation to something else that's going on. So the most common thing is like a low oxygen environment. So emphysema patients, like emphysema COPD patients that are non-compliant with their supplemental oxygen. I had a guy a few months ago that came in, pretty bad COPD, didn't like wearing his oxygen, still smoked. He walked around with an oxygen saturation average, you know, it was like 82, 83%, and his hematocrit was 60% when he came in, 60%. And that was his body trying to keep him alive, right? So he had low oxygen levels. So the only thing that the body could do, it couldn't increase his oxygen level. Only he could do that, and he was refusing. The only thing that he could do about it, or that his body could do about it, was increase the number of red blood cells, and that's what it did. He had I don't remember what his hemoglobin is, but it was quite high too. If I had done phlebotomy on that guy, I potentially could kill that guy. Okay, so phlebotomy is not indicated in these secondary conditions. The other low oxygen status or state that I see sometimes with high hematocrits, although, yeah, it has to be pretty bad. Sleep apnea. If you don't use your CPAP machine, again, you have low oxygen at night. It starts stimulating, red blood cell production. But the most common one too in other parts of the world, at least far away from where I live, is people who live chronically at high altitude. And people that live at high altitude can have some like shockingly impressive hematocrits. This is, I want to show you a paper here that shows that. This one is from Frontiers in Physiology. When was this published? July 2020, so it's pretty recent. It's called Excessive Erythrocytosis and Chronic Mountain Sickness in the Dwellers of the Highest City in the World. So where's the highest city in the world, you may ask? Well, it's La Rinaconda, Peru, okay? So this is what it looks like there. Now, I'd never heard of this place before. The city's kind of, it's more of a town. It's sprawling over, different altitudes, but it's somewhere between like 5,100 and 5,300 meters. So you're talking close to like, these people live at 17,000 feet for years and years and years and years. And you know what? Turns out they do just fine. Turns out they do just fine. And I want to show you some of their numbers because it's going to blow your mind. So this place, you might like, why the hell would you live at 17,000 feet for your whole life, or for at any period of time? Well, apparently there's a lot of gold in their hills up there. So there's gold mines up there. Living conditions apparently are pretty terrible up there. As you can imagine, it's really hard to get supplies in and out of there. So I think most of the people that reside there are involved in the gold mining industry, so they tend to be younger people. So in this particular study from Frontiers in Physiology, now they were looking at they weren't looking at clots in these people who are mostly men. They were actually looking at how many of them got mountain sickness or high altitude mountain sickness, chronic mountain sickness, and it turned out that their rates of mountain sickness, which again this is not relevant for TRT, but it's just interesting. They really weren't different than other populations that were living, also at high altitude, but not quite as high. So people that are living at like between, 2,000 and 4,000 meters, for example, they had kind of similar rates of chronic mountain sickness. But this chart here looks at the population. Average age was 32 years, overwhelmingly men. Look at their average hematocrit. Average, or median, I should say, 60%. 60%. So half of them walked around with a hematocrit higher than 60%, half were lower. That's what median means. Average SpO2, or oxygen saturation, on their little pulse oximeter, 82%. And they're mining gold, they're walking up and down the streets, they're living their lives with hematocrits, in many cases, above 60%. Pretty impressive, okay? So altitude can have a big effect. So, again, they didn't specifically look at blood clotting or strokes or PEs and stuff in this population, but there are studies that do. All right, so here's a second one. This one's in Ecuador. So this is also Frontiers in Physiology, great journal. Stroke-related mortality at different altitudes, a 17-year nationwide population-based analysis from Ecuador. So not quite as high as their colleagues over there, their cohorts in Peru, but pretty high. Like these people were somewhere between I think they compared mostly like 2,500 to 4,000 meters. So still getting up there. These all had high hematocrits. I believe they were in like the 54% range ish, more or less. And this chart pretty much tells it all. So it looks at the rates of stroke for people that lived at low altitude and then people that lived at high altitude, and they plotted it by age. So the age is going to the right. And then, on the left, the y-axis, you have the incidence of stroke. So, not surprisingly, as you get older, your chance of stroke goes up. Doesn't matter if you live at sea level or you live up in the mountains. That's just how it is. So the blue line, these are people that lived at low altitude. And check out the high altitude folks. Okay, they were less. So high altitude in this particular study in these populations over 17 years, you were less likely to have a stroke if you lived at high altitude and had a high hematocrit as a result of that than you were if you lived at low altitude. Okay, now did they look at DVTs and PEs in this study? No, but they looked at stroke, which clearly, like thrombosis for the vast majority of strokes, is one of the primary mechanisms. Okay, so these populations, high altitude, high hematocrits, well above 50%, you know, where some of these clinics start freaking out, and well above, in many cases, the 54% threshold that the Endocrine Society and these other urological societies look at. So I thought that was pretty interesting. The Peruvian one is really impressive, 60%. Testosterone, it turns out, is also associated with high EPO levels. So you can lump the erythrocytosis that happens with high testosterone. You can lump that in as this is a secondary erythrocytosis. Okay, the bone marrow is responding to actually increased EPO levels from testosterone, which testosterone, you know, the exact mechanism by which it raises hemoglobin and hematocrit, they haven't quite pinned it down yet. It's thought to be multifactorial, but high EPO levels and I believe lower hepcidin levels are two of the things that seem to be, that's like the going theory that causes these hemoglobin and hematocrit levels to go up. All right, so again, we know that secondary causes of erythrocytosis are not associated with these adverse outcomes that you see with primary. Yet somehow, you know, I think many of these providers they're committing a logical fallacy of they're context switching. Okay, they look at somebody, or they look at data with people that have high hematocrits with, for example, polycythemia vera, and they see that they also have high incidence of stroke. And then they look at men on testosterone and they see that they also have high hematocrits and therefore assume that they also are at risk for high risk of stroke. But that's not the case. These are two completely different conditions who just happen to both have high hematocrits. Polycythemia people, as I just was telling you, they clot for other reasons besides high hematocrit. Okay, maybe there's some contribution from their hematocrit, but they primarily have platelet dysfunction. There is no platelet dysfunction in erythrocytosis from testosterone replacement. Okay, certainly not at physiological levels, which is what you should be doing. Okay, so here's an additional paper that kind of supports this. So this is called Reevaluation of Hematocrit as a Determinant of Thrombotic Risk in Erythrocytosis. Journal is Hematologica from 2019. You can look it up, and you can look all these up and read them if you want to get the full paper. But I just highlighted some of the relevant things here in the abstract. So the first thing I'll highlight, and I'll just read it off to you. Thrombosis is common in Chuvas erythrocytosis. Okay, that's like a rare genetic erythrocytosis that I think was first discovered in some little podunk village in Russia. So Chuvas erythrocytosis and polycythemia vera. Okay, we know that. It's common. Although the increased thrombotic risk is assumed to be due to the elevated hematocrit and an associated increase in blood viscosity, thrombosis does not accompany most types of erythrocytosis. Okay, what I mean by that, most types of erythrocytosis are secondary. They're not primary. Okay, these primary ones are actually relatively rare. The next highlighted phrase here, inherited and environmental causes that lead to polycythemia and erythrocytosis are accompanied by diverse cellular changes that could directly affect thrombotic risk, irrespective of the elevated hematocrit. Okay, it's not the hematocrit, guys. It's in these other conditions. It's platelet dysfunction. It's dysfunction within the coagulation cascade. There are going to be a number of other variables besides hematocrit. Okay, and we know that because with polycythemia vera, you can phlebotomize these people down to a normal hematocrit, and they still are at increased risk for clots. That's because that's the nature of the condition. Okay, so anyway, I just wanted to touch base with you guys on that. I don't want you to be afraid. If your clinic calls you and says that your hematocrit is 51%, you don't have to freak out. I have seen guys get absolutely terrified by their providers and urgently rush down and try to get phlebotomy down at the Red Cross because they've somehow crossed this magical 50% threshold. It's completely unnecessary. I really wish that some of these providers would just read the medical literature, try to keep up with this sort of stuff, and stop scaring their patients, because it's entirely unnecessary. All right. So that's all I have for you guys today. In my practice, I follow the Endocrine Society guidelines, and I personally use 54% as a cutoff. I don't freak out about it. I follow it primarily for medical legal reasons. The book has not been shut on this yet. There may be studies showing that maybe there is an increased risk, and I'm wrong. But the overwhelming, this is just these journals that I showed you guys today, this is just a small fraction of what I could have included in this talk. We don't have all day for this, and I don't want to bore you with it, but the overwhelming number of studies show that testosterone therapy is not associated with increased risk of clotting. So DVT, pulmonary embolism, stroke, myocardial infarction. And in many cases, some of the studies that initially showed that there may be a risk, there was one in the urology literature years ago that said in the first year of starting testosterone therapy, there was an increased risk of thrombosis. Well, it turns out that when they reviewed that and they eliminated all these other risk factors, specifically smoking and obesity, it turns out that wasn't the case. It was the smoking, the obesity, and some of these other risk factors for having a stroke or a clot that were primarily the main factor. And the other big one too, I forgot to mention, is one of these hereditary clotting disorders, which are surprisingly common. Okay, if you're of Northern European ancestry, factor V Leiden deficiency, if you're from that population, it's somewhere like, I think if for heterozygotes, meaning you carry at least one copy of the gene, it's somewhere around 8%. So many of us are walking around, it runs in my family, with one or more copies of this factor V Leiden mutation, which in and of itself increases thrombotic risk. So that's when they went back and looked at these studies and they excluded people that had these thrombotic risks and had these other risk factors. All of a sudden it turns out that the testosterone, there's no difference between that and the control group in the vast majority of these studies. So I don't mean that you don't have to, you still have to stay healthy. You need to keep your weight down. God forbid you smoke. You got to stop smoking. And if you have a family history of blood clotting disorders, you probably should talk to your doctor about getting tested for one of these thrombophilias. There's at least 5 or 6 major ones out there. And like I said, they're not that uncommon, depending on what your population that you originate from. So don't freak out about hematocrit. If your doctor wants you to go get one, fine. But personally, I stick to the Endocrine Society guidelines. I use 54%, but I know where that recommendation is coming from. It is certainly not the most evidence-based guideline that they've ever put out, and I'm hoping eventually it will go away. So that's all I have for you guys today. If you have any comments on this, please leave them in the comments section, and I will catch you next time. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.